Hello and welcome. I am Mandel Scher. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for the first of two CMEO podcasts in the series Chronic Cough, a burdensome journey with new therapies on the horizon. This episode is the pharmacist's role in improving early diagnosis for patients with chronic cough. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. This activity is supported by an educational grant from Merck Sharp and Dohme Corporation, a subsidiary of Merck and Company Incorporated. Again, I'm Mandel Scher, founder of Scher Allergy Specialists and Center for Cough in Largo, Florida, and I'm a clinical professor of medicine and pediatrics at the University of South Florida Pediatric and Immunology Program located at Johns Hopkins All Children's Hospital. I'm pleased to be joined by Dr. Megan Adelman. Dr. Adelman is a clinical pharmacy specialist at the Cleveland Clinic, Akron General Center for Family Medicine in Akron, Ohio, and a clinical adjunct professor of Family and Community Medicine at the Northeast Ohio Medical University in Rootstown, Ohio. Welcome, Megan. It's so great to have you joining me today, and my hope is that we will be able to align our provider and pharmacist insights to really move the care of patients with chronic cough towards better outcomes.
Thanks, Dr. Scher, for that introduction. It's absolutely my pleasure to be here today, and I'm really excited to have this discussion on an important topic that I think really pharmacists can get involved in to help patients along their journey with chronic cough.
I agree with that. What we were going to do, just to sort of frame today's program, is to start by reviewing our two learning objectives. After participating in this activity, the learners should first be able to recognize the clinical presentation of chronic cough, a condition that carries an under-recognized and unappreciated burden to the patient. And the second learning objective is to provide guidance to patients about appropriate actions to take to receive an accurate diagnosis and treatment plan for chronic cough. Specifically, how pharmacists can best help their patients in their journey through this difficult and burdensome condition. You know, Megan, our audience may be thinking, hey, I already help people with cough all the time. It's one of the most common problems I make recommendations for in the pharmacy. What's the big deal here? So why don't you kick us off right away with a patient case?
Thanks so much for that. I totally agree. As pharmacists, this is something that we face quite frequently, especially cough, and it's an extremely common complaint that depending on the season we see. Let's start with the case. So this is one that I think is applicable to many pharmacists. We'll start with Lisa, who presents to the local pharmacy, asking the pharmacist if there's anything new or different she can try for cough. It's apparent that she struggled with this, hence the discussion with the pharmacist. She's a 61-year-old female, has no prior history of smoking. And while this is the first time that Lisa has ever come to you, you've seen her around. She's wandered the aisles, especially in the over-the-counter, and she mentions in passing that she's tried various therapies in the past. We go into our Quest Scholar mode, as many of us remember, to elicit a little bit of a history. So she states that she's had a dry cough, that she ends up saying is a throat tickle. Thankfully, the cough somewhat resolves at night, but it's pretty consistent throughout the day. And she describes a postnasal drip, but very minimal mucus. You're surprised to find out that she's actually been dealing with this for 3 years. And this is really after a detailed discussion with her that she admits to this. And it started following an upper respiratory tract infection. There's multiple different irritating factors to her, triggered by talking, sense odors such as perfumes, and changes in the temperature, so it waxes and wanes depending on the season. You're also pretty surprised to find out that not only has she been dealing with this for 3 years, the cough is just the tip of the iceberg. There's multiple sequelae that come along with it, including incontinence when she starts coughing. And because it's been happening for so long, she really feels frustrated, isolated, and anxious because multiple family and friends have talked about how much of a burden this is. And we really start to see this with COVID too, because of that social isolation, that she did not have COVID, but this is one of the symptoms that we see along with this. You just further discuss the transition with Lisa, and you're so surprised to find out that this is not her first rodeo with this, that she's actually been to her primary care provider, that then because of the ongoing failure with treatments, she saw multiple other specialists, including two ENTs, a GI, a pulmonary specialist, an allergy specialist. So she's been on this journey for quite a while. In going to the specialist, she's tried multiple therapies, including courses with PPIs, omeprazole, as well as intranasal and inhaled corticosteroids and an antihistamine. When we think back to the pharmacy, she's tried multiple over-the-counter products, many that we see frequently go out of our pharmacies. So dextromethorphan, guaifenesin, codeine, and as you're standing in the aisle, she points to almost all of them. She does say that there's some factors that help. So throat lozenges and sipping on water is somewhat helpful, but over a very limited amount of time. And that she had a brief course of prednisone that she said was helpful. But as we can see, multiple failures versus the benefits. Dr. Scheer, I feel like Lisa's like so many patients that we see, both in the pharmacy and I'm sure from your standpoint. Can you talk a little bit more about how you would characterize her cough?
Absolutely, Megan. And let's talk about what could be the causes of her cough. And the way we look at cough is usually about the duration of the cough. We break it up into three basic frameworks versus the acute cough, which is the most common. It's occurring under 3 weeks. And the most common cause by far and away is going to be viral upper respiratory infections. And that's what the pharmacists and as healthcare providers we're going to be dealing with primarily. But immediately we got to think about more serious conditions that could be presenting, be it lower chest pneumonia, heart failure, foreign body, malignancy, and that's always, it has to be brought up in our minds. We then go into what we call a subacute cough, lasting 3 to 8 weeks. The majority of that's going to be the remnants of the viral upper respiratory infection, either causing a post-viral kind of neuropathic irritation or inflammation. But again, we always need to be thinking about those underlying conditions. And it's about that point that a cougher at that point should be seeing medical care. And I like to make the point that a chest x-ray is always important because it really rules out particularly malignancy. So anyone with a prolonged cough should be getting a chest x-ray. What we're going to be talking about the majority of today is the chronic cougher. The cougher who has a cough greater than 8 weeks. And there's generally broken up into kind of anatomic causes for this, of which there could be a combination. Upper airway, which includes allergic or non-allergic rhinitis and sinusitis. Lower airway, be it asthma or an asthma-like inflammation or ongoing infection. And then be it gastroesophageal, be it acid or non-acid reflux. And it could be one, two, or all of these three contributing. Another would be drug-related, particularly that of the ACE inhibitors, which can contribute to an irritative cough. And this is the framework that we use as we approach to see anatomically what's going on with the cough. What I think is important for the healthcare provider, the pharmacist out there, is to kind of appreciate some of the warning signs of something that could be significant. And Megan, could you kind of review some of those warning signs for us?
Yeah, thank you for that. I think we go back to our basics as to really the question underlying that we should be asking, especially in the community setting, is, are you a candidate for self-care? Dr. Scheer, as you mentioned, to me, one of our guidelines is this even subacute? Is this chronic in nature? Once we get into those categories, patients rule themselves out as candidates for self-care, that we really do need to ask the question, have you seen your provider? Because this is not an area where pharmacists can treat. There may be underlying factors, as you highlighted on the prior slide. There may be other disease states going on. So this is really where pharmacists are in an ideal option to say and position that we need to see further care by a specialist or your primary care provider. All of the other symptoms I've highlighted on this slide, but I just wanted to name a few that I start to have red flags go up that maybe we need to see a provider, is if we have a prior smoker or a current smoker, if somebody is complaining of shortness of breath or dyspnea, any sputum production, as well as systemic complaints such as weight loss, signs and symptoms of GERD, fever, malaise, any of those, really we need to start thinking more outside of the pharmacy, OTC therapy versus saying it's time to go to a provider. I also want to take a look at what we would refer to as exposing the opportunity for pharmacists. I think it's very common for many of us to look at among the aisle for over the counter and see multiple individuals, especially in the cough and cold section. We not only need to look at just what they are trying to purchase, but then also having a conversation about the burdens that the patients are facing so that we know appropriately how to help. Key things that we need to remember is that many times we're only seeing the tip of the iceberg. So the discussion of cough is really just the beginning. And we saw that in Lisa's case. So they may be standing in the aisle, but then we need to do those follow-up questions. What else are you experiencing? Frequently, individuals with chronic cough are feeling some sort of social isolation, frustration with the healthcare system because they're seeing so many other individuals, social isolation because their friends and family are commenting, fatigue, stress incontinence, and the other sequelae that we talked about with Lisa's case. This is a phenomenal opportunity that pharmacists have that we can step in and help be a support system so that patients can further seek that additional care if needed. Frequently, we may be missing these patients because we're just not asking those appropriate questions. It's so common for us to see those over-the-counter agents be purchased, so we're just allowing that purchase to occur without stepping in and asking about some of the key questions. What else have you tried? How long have you been experiencing this? Dr. Shear, I'm always so surprised to see this overlooked in the pharmacy because we so frequently see these over the counter. Can you comment at all about what you see in the outpatient setting?
Megan, I have to totally validate what you're saying, that what you're seeing is also being seen in the doctors and the healthcare providers' offices. The burden of chronic cough to these primarily women, but also men, who have depression, who are socially isolated or physically being assaulted, is really underappreciated in our medical community. This is for reasons that we're not fully understand, but I think there's two factors here. One is that when it comes to chronic cough, it can be very complex. There can be multiple anatomic kind of contributions to it. And as we'll talk about, what has been unappreciated is that chronic cough, for the most part in many conditions, is actually due to cough hypersensitivity, which is something we'll talk about at length. Furthermore, we don't have really great therapies. The last drug approved by the FDA was in 1958. That was dextromethorphan and benzonatate. So as we will talk about, that our armamentarium from a pharmacologic standpoint is just not acceptable. We either have drugs that work that have significant side effects, or drugs that are safe that don't work. And I think that leads to a frustration on pharmacists and particularly the healthcare providers who really can't offer a lot. So I think they tend to minimize this problem as just being a nuisance. So let's just take one example, and that's just the cost of care and medical and pharmaceuticals. And can you address that, Megan, for us?
Yeah. We didn't even touch upon it on the prior slide, but individuals on average are spending thousands of dollars for this care. So between the specialist, between their primary care providers and the agents. And again, this is another opportunity where pharmacists are just seeing the tip of the iceberg. Over-the-counter cough and cold products are our leading agents for sales, and the other ones combined don't even hit the sum of what these targets are. So again, patients are frequently coming in trying different agents, and again, highlights another opportunity, not only for the socioeconomic burden of it, but then as we talked about, the social component of it, the other sequelae associated with it. I want to give you just not only on the economic burden of it, but what pharmacists should also be looking at. Lisa highlighted many of these. So when we should be thinking about red flags, patients that maybe we need to ask a few more questions. So not only are we thinking about the economic burden associated with this, but then we also need to think about what are the social factors for this and how can pharmacists start to think about who are these patients. Frequently, most of these patients are a little bit older, so 61 years old, frequently female. So if we think about Lisa, this fits the characteristic quite well as to when we might want to step up and intervene, ask a few more questions. Additionally, the other thing that we need to think about is that these individuals come in with many other chronic conditions potentially, meaning that there's other drugs that come along with that. While our treatment strategy for chronic cough follows a lot of other pathways for disease states. So if somebody has asthma, we're trying an inhaled corticosteroid for treatment. If they have GERD, we're trying a PPI. So as a pharmacist, we need to be thinking about not only asking the reason for the medication, but then is the cough, if it is being used for cough, is the cough getting any better? We can then help to delineate and support those patients. Hey, we might need to go back to the provider that this is a failed therapy. Dr. Shear, I think this highlights too that if patients aren't getting better on these therapies, that's a failed treatment. Maybe there's something else going on. What are your thought process for that?
Absolutely, Megan. This introduces a newer concept that's emerging over the last decade. We have these primarily women. They tend to be in their 50s and 60s, but we also get men. They tend to have a dry cough. They complain of mucus and postnasal drip, but they don't make it. They have irritable triggers such as even talking and smells and air conditioning. Of note, the cough tends to go away during sleep. And so we have this characteristic of a patient population. And what we're finding is that in addition to these anatomic contributions, which may or may not contribute to cough, there's this concept of cough hypersensitivity, which we'll go into. But first, so there's a new designation of how to define this patient population. Could you review that for us?
Absolutely. So we have two different primary definitions that we think about for chronic cough. The first one being refractory chronic cough, which is one that persists despite guideline-based treatment, some of which we've talked about, the PPIs or inhaled corticosteroids, for underlying conditions such as GERD and asthma, respectively. Our second one that we think about, though, is unexplained chronic cough. So one that persists longer than 8 weeks, but then remains unclear despite investigation. Now, we have another term on the slide. Dr. Shear, can you go into cough hypersensitivity syndrome a little bit more?
Absolutely, Megan. So to understand cough hypersensitivity or an irritable neurogenic cough, we have to understand a little bit about cough the reflex. And it's really important for pharmacists to understand that because they'll understand the pharmacology of what we're trying to treat. So we have two basic cough reflexes. We got that true protective cough reflex. It protects us against objects and acid from food that's being aspirated, from stomach contents being aspirated. When you've got an infection, you got mucus, you've got to clear it out. This is a very strong reflex. It's really hard to suppress pharmacologically. It's even seen when you're asleep or anesthetized, and it's meant for survival. The other cough reflex, or actually cough response, is an irritative cough response. It occurs with various irritants, smells, viral infections. And it's almost universally associated with an urge to cough that's generally in the throat or sometimes in the chest. It's that tickle in the back of your throat, and they will lead to the cough. It is seen when we're conscious, but of note, not when we're anesthetized or asleep. So some of these characteristics will help us lead to this neurogenic cough. And what happens into our patients who have chronic cough is that this irritative cough reflex response is hyperactive. These coughers feel things more than other people, and their ability to inhibit responses is decreased. So they tickle more and they cough more. And this condition has been referred to as cough hypersensitivity. And in those individuals who are having chronic cough, there's no identifiable anatomic contribution or medication like ACE inhibitors. They most likely have cough hypersensitivity as unexplained chronic cough. Or if they have conditions such as GERD, asthma, or rhinitis, it's being optimally treated and they're still coughing, That's what we call refractory chronic cough, which, though the core pathophysiology is going to be this cough hypersensitivity. And that is really a new concept that will lead us to diagnosis of this condition and actually therapy to this type of condition. So, what I like to talk about at this point is that when it comes to this, the therapy, as I alluded to, where one is learning the different pathophysiology, neurologic pathways for this, we do have drugs that we use off label for cough hypersensitivity, such as gabapentin, pregabalin, amitriptyline. Actually, in England, they use slow release morphine as the number one drug. But these are drugs that do have some shown efficacy off label, but have significant amount of side effects. And what's been developed and what's exciting, which is what we'll talk about primarily in the next podcast, will be the different pathways, particularly P2X3 receptor pathway, where there are novel cough drugs that are proving to be effective with less side effects. So what we've done now is illuminated some very important points that are commonly overlooked and not recognized in patients with chronic cough. So Megan, why don't you take us back through the patient case and tell us what you think the touch points are for interventions by the pharmacist.
So thank you for that. I agree. This is a great case that, again, I don't think is isolated to just one patient case. While this may be rare versus more of your acute cough, I think there are some key takeaways from Lisa's case that we can discuss. So we found out upon questioning that she did see multiple individuals, starting with a primary care provider, but then also some specialists to go along with that for the care. This really highlights the opportunity to discuss with patients who they can seek help from. In what order do we see it? And that we can encourage individuals that there are other individuals to talk to if this continues to be an ongoing complaint. These individuals frequently are going to be the ones that are not complaining. They've dealt with it for a while, so this may be something that they think is just going to be a lifelong ailment. Additionally, Lisa noted that she was unresponsive to multiple therapies, not just over the counter, where we really see individuals as a touch point as a pharmacist, but something prescription. So intranasal and inhaled corticosteroids, antihistamines, courses of PPIs. And this really highlights the opportunity of the pharmacist to get out from behind the counter, as well as out from the hospital, and ask patients, why are you taking these? Is it getting better? Is there anything that we can be utilizing and saying, just because this isn't working now, there's always individuals to go back to seek additional therapy. Lisa also noted that she felt fairly isolated. She's talked about this with family and friends who have asked her to seek additional treatment, even though she's doing that herself. So she's probably fairly frustrated, depressed. And this is a great opportunity for the pharmacist to come in and say, we can be a support system. We can help you through this. And we can help navigate the additional care when you feel like you're the only one going through this journey. We also found out that thankfully Lisa had some remitting factors. So she had throat lozenges, sipping on water, and she responded briefly to prednisone. This is really where the pharmacist can say self-care is probably not the ideal option in this case. And then finally, the pharmacist recognizes the patient as a frequent visitor, but unaware of reasons for trying various therapies over the years. And this is probably my key take-home point from the slide, is that we frequently allow individuals to do self-care, to go through the over-the-counter areas without really talking with them. And I am so surprised with Lisa's case, and really highlights what we probably would frequently see, that if we had not talked to her, we wouldn't have found out many of that information, and she would have left with just an over-the-counter product and likely just continuing to come into our pharmacy without additional care.
Hey, Megan, that was terrific, and I really appreciate you joining me in this discussion. So why don't you close our program with some SMART goals, which are SMART, measurable, attainable, relevant, and timely.
Yeah, thank you, Dr. Shearer. I've really enjoyed this discussion, and I hope it highlights some key things to challenge pharmacists. So leaving with that, we want to challenge you to make sure that you're talking to your patients presenting with cough prior to just recommending cough products. And again, highlighted on the last slide, I think we find out a lot by going through our traditional Quest Scholar method. We also encourage you to facilitate patients who have chronic cough to take the next steps, whether that be seeing a provider. If therapy is not working, having courage to go back to the provider to see if other options are available, or even seeing a specialist, but really helping to be that support system for the patient. And then finally, we've talked about this cough hypersensitivity syndrome. While we wouldn't do a full diagnosis in the pharmacy, I think it's important to encourage patients that there may be an underlying factor if we've had multiple failed attempts. And then again, this is an appropriate time to go see a specialist to make sure that care is adequate.
Okay, I want to also remind our audience that this is one podcast of a series of two, and I hope you will join us to listen to the other podcast that's titled A Guide to New and Emerging Treatment Options for Chronic Cough. Please remember to collect credit for this activity by clicking on the button that states Apply for Credit. You will need to provide your NABP number so that we can report your credit. On behalf of Megan and myself, thank you again for joining us today. I do want to let our audience know that we are developing additional resources on how pharmacists can recognize and refer patients to the appropriate provider. Please visit a link that you'll be provided for access to these resources that will be available in the coming weeks. Thank you very much.